Hi, I'm McKenna Johnson, and my project is on nurse-initiated order sets and their effect on the length of stay for patients seen in a rural emergency department, a quality improvement project. So this is my committee. My chair was Dr. Ashton Lindsay, my second reader was Dr. Boniface Stegman, and my community members were Brett Nance, the medical director of the targeted facility, and Rhonda Merriweather, the nursing manager of the department. Overcrowding in emergency departments remains a widespread issue, particularly in rural settings. This has a direct impact on patient safety, satisfaction, and hospital efficiency and revenue. Studies have shown that delays, especially in receiving laboratory results, significantly contributed to longer lengths of stay, which can increase the risk of medical errors, mortality, and patient dissatisfaction. Abdominal pain is one of the most common complaints associated with extended wait times due to the need for diagnostic workups. Research did highlight that even small improvements in lab turnaround time can lead to measurable decreases in patient stay. For example, one study found that a 1-minute reduction in a lab result time corresponded to a 30-second reduction in the overall length of stay. Nurse-initiated order sets have shown promise in addressing these challenges by expediting care. When implemented, they have not only helped reduce diagnostic delays, but also improved early symptom relief and overall workflow. This project explores how these nurse-driven protocols can be an effective solution to improving patient outcomes in rural emergency departments. So the purpose of this scholarly project was to implement and evaluate the effectiveness of evidence-based nurse-initiated orders in the emergency departments for patients presenting with abdominal pain. It determined if nurse-initiated orders reduce the length of stay and lab turnaround times compared to a physician ordering. The order set that was used for this project was provided by the organization, and it was being used in other facilities, but had not yet been implemented at the targeted facility. The aim was to decrease the length of stay in adult abdominal pain patients by reducing the time between patient arrival and diagnostic results. Furthermore, implementing the nurse-initiated order set created opportunities to expand nurse-driven protocols for other chief complaints, supporting timely diagnostics testing as nursing knowledge and confidence increased. Evidence-based research plays a vital role in advancing patient-centered care, shaping healthcare policies, and practice and outcomes. At the heart of this project is the nurse-initiated order set, a tool that supports early diagnostic interventions, particularly important for patients presenting with abdominal pain. This initiative has significance across 3 levels, which are nursing, healthcare systems, and advanced practice nursing. From a nursing perspective, the project aligns with Chin and Kramer's 5 patterns of knowing, including empirics through observable clinical signs such as self-reported pain, which is the gold standard, vital signs, and physical assessment. Personal knowing by applying unbiased care and the patient's chief complaint and the nurse's experience. Aesthetic knowing by recognizing each patient's unique experience, including their refusals, patient education, and communication with the provider. Ethical knowing by making moment-to-moment care decisions, such as utilizing the order set or not, and urgency. Emancipatory knowing by ensuring equitable care delivery to all patients, which include the same order set that is ordered and completed in triage. The nurse puts in the order set after triaging them and then completes them right after in triage. In terms of healthcare impact, abdominal pain makes up 5 to 10% of all emergency visits. Extended wait times for labs increase patient risks for financial burden. Delays, even 10 minutes, can increase costs up to 6%. Nurse-initiated protocols have been shown to reduce wait times, improve patient satisfaction, and enhance quality of care. Lastly, for advanced practice nurses, this project reinforces their responsibility to anticipate patient needs and drive evidence-based change. By initiating appropriate testing earlier, nurse practitioners can directly improve safety, efficiency, and reduce unnecessary costs for both the hospital and the patient, especially in a critical department in a rural setting with limited resources. In reviewing 19 peer-reviewed articles, 4 central themes emerged, which are overcrowding, interventions, factors that affect the length of stay, and the importance of education. Overcrowding continues to strain emergency departments, especially in rural areas, leading to increased mortality, longer wait times, and decreased patient satisfaction. Nurse-initiated order sets were highlighted across the literature as effective interventions, reducing delays in labs and imaging turnaround times and expediting treatment, especially for patients with abdominal pain. And there were other things that affected the length of stay that many of these articles mentioned, that it can be societal, healthcare system, and individual, and just how important education is in implementing any kind of nurse-driven protocol and following up with audits and compliance. So again, just patient level and system level variables were also shown to influence the overall length of stay, such as comorbidities, triage level, and ED workflow inefficiencies. Successful implementation of nurse-driven protocols was closely tied to proper education and, of course, staff buy-in. If you have staff resistance, it makes it difficult to have a nurse-initiated protocol. However, despite strengths like large sample sizes and operational metrics, most studies were retrospective, so we weren't actually seeing it in lifetime with human subjects, and had limited generalizability just because they were small sample sizes and usually in one or a couple facilities. Gaps remain in comparing different protocols, since many of the articles were different types of nurse-initiated orders, and assessing patient-centered outcomes like the overall satisfaction after implementing the protocols or the quality of life post-discharge. So we're not seeing any of those long-term considerations. And a lot of these articles are not including other variables that may be affecting the length of stay or diagnostic times. But these findings guided the design and the focus of the overall DNP project. Another thing that I mentioned in my limitations is that it does not include pediatric or OB populations, but that could be according to my research, since my project was focused on adult abdominal pain patients, and they were purposely excluded from this project. But that is something to take into consideration as well. This project was guided by Cotter's 8-step process for leading change, which provided a structured approach to implementing nurse-initiated order sets for abdominal pain patients in the emergency department. The process began by creating a sense of urgency around the need to reduce the length of stay and improve outcomes, especially in rural settings where delays are more impactful. A strong coalition was formed, including leadership such as the medical director, ED manager, data analysts, and the project faculty. Together, we developed a clear vision for change, communicated it consistently through staff meetings, presentations, email, education flyers, and engaged the staff to foster early adoption. Barriers such as resistance or technical dependence were identified and addressed through training and open discussion with staff. And support was offered along with more education as needed and other training challenges. Short-term wins like faster lab turnaround times were shared with staff to build momentum. The project sustained change by reinforcing successful practices, embedding the protocol into culture, and planning for long-term integration through onboarding, education, and ongoing feedback with staff. Overall, Cotter's framework provided a roadmap that emphasized both leadership and engagement, ensuring the intervention was not only implemented but sustained. Using this framework, it affected the project in a positive light. I think it gave a very good roadmap into being able to implement and sustain a nurse-initiated order set in an emergency department. This project used quantitative retrospective design to evaluate the effectiveness of nurse-initiated order sets for adult abdominal pain patients in a rural emergency department. Prior to this initiative, the facility had no existing protocol for nurse-initiated orders, but did have them in their larger facilities. The intervention involved developing and implementing an evidence-based abdominal pain order set, which allowed nurses to initiate diagnostic labs before physician evaluation. Staff education sessions, along with a pre- and post-education questionnaire, ensured that nurses were prepared to use the order set appropriately prior to implementation, and data was collected through a retrospective chart review of electronic medical records before and after implementation. The time frame for data collection was 3 months pre-intervention and 3 months post-intervention, with a target sample of 204 patient encounters, which would be 102 in each group. Only adult patients presenting with a chief complaint or ICD-10 code of abdominal pain were included. This methodology helped determine whether nurse-initiated order sets reduced emergency department length of stay and lab turnaround time, and it structured nurse education if structured nurse education contributed to successful protocol adoption. So this is kind of some things that I already went over, but it was a retrospective chart review. It's targeted in a rural emergency department. Just to give you guys kind of a clear sense of what kind of emergency department. It has 4 beds and 2 trauma bays and 2 triage rooms. It does overflow a lot into the surgical beds during those high influx patient demands, especially in the growing community. You usually only have 2 nurses in the ED at a time with 1 provider, and then you have your registration up front. And we can see anywhere from 15 to 30 patients in a 24-hour period, where most of those patients are from 5 p.m. to 11 p.m. at midnight. You'll see around like 15 to 20 just during that time frame. I mentioned the ICD-10 codes. That are all the codes that are going to fall within abdominal pain that are 18 years and older. MD Clone is a data analysts program that is utilized within the facility of their data analysts, so they helped provide the data that I needed according to that program. I also wanted to make sure that my pre-intervention and post-intervention were within the same time frames from October to December to give me the most accurate data possible, because those are going to be close to the same influx of patients at each year, or as close as possible as we can get. So this is my inclusion and exclusion criteria. So of course they had to be 18 years and older. Again, those ICD-10 codes or chief complaint of abdominal pain, and the EMR had to have documentation that the patient was under the care of the targeted emergency department between the pre or post intervention dates. And then during the pilot, the EMR had to have documentation of abdominal pain and the nurse-initiated order set. The exclusion criteria is pretty much all the opposite of what I said. This design was selected because it was a clear yes or no on whether they qualified for the order set, and it was easier for data collection on both post and pre-intervention, and it helped me answer my inquiry with the MD clone program. We were able to see when the patient checked in, when they checked out, their overall length of stay, when they were seen, how old they were, and so on, to help me get the answers I need. We were able to even input when the first lab was ordered and when it was collected, so I can determine that turnaround time. I just wanted to throw this in here just so you guys can kind of know what order set we were kind of working with. This is the order set that was provided by the facility. As you can see on the standing order, it's mainly vital signs monitoring and blood work and oxygen as needed. There is some urine, and depending if they're 35 or older is depending on if you do like an EKG or other blood work. And this is my sample. So my population was all adult patients 18 years or older presenting with abdominal pain to a rural emergency department. The time frame was October 1st to December 31st of 2023 was the pre-intervention. Post-intervention is the same time frame, just in 2024. My total sample size was 396 patient records. 210 were pre-intervention and 186 were post-intervention. So, data analysis. To evaluate the effectiveness of nurse-initiated order sets, the project utilized a carefully designed data collection tool developed through a comprehensive literature review. Key data points such as time and type of first lab results, the ordering provider, and the patient's length of stay were collected from de-identified electronic medical records from MD clone and imported into a secure Excel spreadsheet. This data was gathered for both pre and post intervention groups with at least 102 records in each group to ensure a statistical power. The data was then uploaded into SPSS for analysis because the variables included both ratio and nominal data. Certain statistical methods were applied. Ratio data represented continuous measurable variables like lab turnaround time, the length of stay, while nominal data characterized whether orders were placed by nurses or whether it was the physician. Nursing education scores collected were pre and post training according to the questionnaire, and they were analyzed as ratio data. To test normality, the Shapiro, Wilk, and Kolmogorov-Smirnov tests were performed. Given the distribution of data, the Mann-Whitney U test was selected to compare differences in outcomes between the pre- and post-intervention groups. This test was used to determine if the observed changes, particularly in lab turnaround time and length of stay, were statistically significant. An analysis supported a minimum sample size of 102 per group, achieving a power of 0.8. This comprehensive analysis approach allowed the project to assess the impact of the intervention with statistical rigor while maintaining strict adherence to HIPAA standards and protecting all patient information, since all of those 18 identifiers were removed. The Mann-Whitney U test was performed because the test for normality did not follow a normal distribution. So the Mann-Whitney U test was able to do a pre and post intervention comparisons compared to if the other one came back with a normal distribution. I would have performed 2 independent t-tests to determine if the length of stay or lab turnaround times were significant. And of course, the effect size was set at 0.05 for statistical significance. So these are just my my visuals of my data. So you can see the pre-intervention length of stay and the post-intervention length of stay, which there is a decrease. And then this is also my lab turnaround times. Again, there's that decrease from pre-intervention to post-intervention with the nurse-initiated order sets. And this was my pre and post-education questionnaire that the nurses had to fill out after the training, which showed significant difference in their education of the nurse-initiated order set. So here's my overall results. You can see what the nurses were scoring prior versus after, and you can see the significance. The length of stay, it did decrease, but however, it was not significant, whereas lab turnaround was. So some limitations: a 3-month time frame may not have been long enough to show the full impact of the intervention. It was only conducted in one rural emergency department, limiting the generalizability to other settings or urban settings. It did not assess patient satisfaction, readmission risk, or long-term health outcomes. Factors like patient acuity, provider availability, or imaging delays may have influenced the length of stay, or even like nurses having a difficult time getting blood from the patient. Staff awareness of being studied could have influenced their behavior, temporarily improving their performance, and limited responses in the pre and post education questionnaires may not fully reflect nursing knowledge retention. Statistically significant reduction in lab turnaround time after nurse-initiated order set implementation. The length of stay slightly decreased, but was not statistically significant with a p-value of 0.742, indicating other factors may have influenced the patient throughput in the emergency department. Knowledge scores did increase from 48% average to 99.5% post-education, highlighting the success of structured training. Physician workflow, diagnostic delays, patient acuity may limit the impact of nurse-initiated order sets on length of stay. Findings align with the past research showing improved diagnostic efficiency, but varied effects on overall length of stay. Results emphasize that nurse-initiated orders improve efficiency, but must be a part of a broader, multifaceted strategy to enhance ED flow. Nurse-initiated order sets significantly improved lab turnaround time, enhancing emergency department efficiency. High post-education knowledge scores support the need for ongoing structured nurse training for successful protocol implementation. Expanding nurse-initiated protocols to other high-volume ED complaints, chest pain, sepsis, urinary symptoms could amplify the benefits of nurse-initiated orders. Embedding order sets into the electronic medical records with prompts can encourage real-time use and consistency in triage. Implementing across different emergency department settings, rural and urban, can increase generalizability and validate effectiveness, and future studies should include patient satisfaction, diagnostic accuracy, cost effectiveness to capture a holistic impact on the patient's care. The results of this project demonstrated that nurse-initiated order sets significantly improved lab turnaround times for adult abdominal pain patients in a rural emergency department. Specifically, the Mann-Whitney U test revealed a statistically significant difference with a p-value of 0.004, confirming that patients who received nurse-initiated orders had faster lab results compared to those who had to wait for physician-initiated orders. However, the overall length of stay did not show a statistically significant difference between the pre- and post-intervention groups, with a p-value of 0.742. This suggests that while nurse-initiated orders expedited diagnostics, other factors still may have influenced overall discharge times. Importantly, there was a remarkable increase in nursing knowledge following the educational intervention, rising from an average score of 48% pre-education to 99.5% post-education. This reinforces the value of structured training in successful protocol adoption. Overall, the study highlighted the effectiveness of nurse-initiated order sets in improving operational efficiency in rural emergency settings, particularly through faster lab processing and enhanced nursing competency. These findings set the foundation for future research and expanded implementation of nurse-driven protocols across various clinical conditions. My DNP program reflection, it has empowered me with leadership and research and implementation skills that will continue to influence me throughout my practice. I also have a different outlook on research, whereas I did not look into research. I looked at it in such a lighter light than what I do now, of all the things that truly go into it. And I will be taking that into my practice a little bit more, on reading different things for my patients to improve their overall quality of care. And these are my references throughout my project. Thank you for listening.